Dana is a 28-year-old cisgendered Black woman who is 39 weeks pregnant with her second baby. This has been a low-risk pregnancy with prenatal care throughout. Her first pregnancy had been uncomplicated with a spontaneous vaginal delivery at term. This time, Dana really desires the care of a midwife and possible home birth, but when researching, she found none in her local area. Because of this, Dana is receiving care at a local hospital covered by her insurance that is discovered from some reviews through the Earth app. The hospital employs midwives, including one Black midwife, but the group is still small, and she was aware that she may not be able to birth with a midwife when labor begins, depending on their schedules. Dana now presents with her husband Malcolm to the hospital after laboring at home with contractions that continue to increase in intensity and frequency in the middle of the night. She is informed while checking in that none of her midwives are on call this evening. The doctor on call came to assess her and immediately said, "Oh, I haven't met you before." He proceeded to start examining her in the middle of a contraction without explanation and despite Dana's request to wait till after the contraction. He insists, "Well, they're just going to get stronger and you'll miss your epidural if we can't evaluate you now. And I need to check your cervix now if we're going to admit you." Dana continued to breathe and focus through the contractions that seemed to hit back to back. After the contractions finished, she let the physician know that she was not planning for an epidural and would like to move around the room to help facilitate her birth. He bristled, "Fine, whatever," and walked out without another word of explanation. Dana's nurse entered and asked if she could examine her cervix when Dana was ready. Dana agreed, and she was found to be 8 centimeters dilated. The nurse exclaimed, "I wouldn't have known. You have so much control." She proceeds with the admission process and then explained that she would leave to gather some supplies. About 30 minutes later, when no one had yet returned, Dana told Malcolm she felt like pushing. Malcolm called the nurse through the call light and told her that he thought the baby was coming. The nurse said she would be right in. However, Dana and Malcolm, as they waited, could hear laughter and someone say, "No, she doesn't know what she's talking about. She just got checked. And she was 8 centimeters. Someone else replied, "We should have just given her the epidural then. At least she would have had 2 more hours before the delivery." With sinking disappointment, Dana focused on her contractions and pressure. Although upset, Malcolm continued to support Dana through her labor. About 10 minutes later, Dana's nurse walked in to find Dana actively pushing and saying, "The baby is coming." The nurse lifted the sheet to find the baby's head crowning with a tuft of the baby's hair already visible. She called for help from her nursing team to alert the doctor for delivery. As this was happening, Dana let out a large grunt, and her baby quickly emerged onto the bed before the nurse could put gloves on and the doctor arrived. Their vigorously crying baby was immediately scooped up by the nurses and handed to Dana. At that moment, the doctor entered the room exclaiming, "Well, that was fast. You're lucky." Dana asked that the doctor delay clamping the umbilical cord, but he replied, "Well, it's been 2 minutes already." Dana felt too exhausted to fight further, so Malcolm went ahead and cut the cord as instructed, and without asking, the nurse immediately took the baby to the warmer. At this time, the attention focused on a new concern. Dana was bleeding heavily. The doctor began to give orders and asked for additional help. Without warning, he stuck his hand in her vagina and Dana screamed. The doctor continued saying, "I have to stop the bleeding. I can give you something for the pain, but we need to stop this now." The bleeding continued. Dana was beginning to feel weak. Her heart rate was picking up and the pain was intense. She asked the doctor for medication and he replied, "Well, you had the baby without anything. This will hopefully be over in just a few more minutes." Dana was too tired to cry. Malcolm could see this and asked again, "Are you able to give Dana something for the pain? This is too much for her." The doctor sighed and called out orders for the pain medication. When the bleeding would not slow, urgent preparations were made to take Dana to the operating room. She was quickly consented and whisked away. Malcolm was left alone, holding their newborn. While Malcolm waited for Dana to come out, a nurse walked over with a bottle of formula. "Here, give this to the baby. The baby needs to eat," she said. Malcolm knew just how important it was for Dana to breastfeed, and the baby was calm at this time, just looking around. Malcolm said, "We plan to breastfeed. I would like to wait a little while." The nurse rolled her eyes and said, "Are you sure? She might end up supplementing anyway." Malcolm said he was sure and asked her to help him with skin-to-skin contact. After some time, a different doctor came to speak with Malcolm and said that Dana's bleeding was finally under control after some extensive work, including a balloon that helped to prevent more bleeding. He stayed to answer all of Malcolm's questions and list out a plan of care and a medication regimen to help her with healing and pain. Malcolm thanked the physician for being patient and explaining things. Dana recovered well and was able to go home about 3 days after her birth with Malcolm and their newborn.
And I'm going to start off with a couple of questions of our panelists. And so I'd like to first ask the question that says, please speak about the communication between the doctors, nurses, and Dana. What could have gone differently? Where could language have been shifted? Where could the team have worked in a different manner? And I would like to start off with Ms. Davison.
I think there's so many points here that language could have been much different. One of the examples was when the doctor went to check Dana and was just really forceful with the situation. And we see this a lot of times. I come from a nursing background, so I understand that nurses can be very territorial, but we have to recognize that this is not our body or our experience. And so honoring the experience of someone else and recognizing that they're in the middle of a contraction, that they're going through something that they need to process, all of that is important for us to get people the help that they need in that time. I tell patients all the time, you always have time. You always have a moment. There's always a moment for us to answer questions, for you to get through your contractions. Even if things are looking like we need to move urgently, there's still a moment of time. And so that's one of the points where I feel like language could have been different. Also, if you're not aware, Black infants are offered milk and formula at a higher rate than white counterparts. And so the offering from the nurse of the formula and suggesting that, that she might need to supplement later is really not any of our business. Our business is to support this person in the time that they need. Again, they had a moment. Dana was off in the operating room. The baby was not fussy. Malcolm offered skin to skin time. So we can proceed there, and then even as the recovery is happening, we can offer skin to skin again with mom when she's out in recovery, and she can begin to breastfeed. So opportunities for us to redirect our thought as well as our language are plentiful in many of the obstetrics experiences that we have. So those are the things that I'm thinking about. The other thing too is maybe not language, but behavior is once the baby is born, oftentimes it's a rush for staff to check off task lists and get things done. So taking the baby to the warmer, I got to assess, I have to give shots, I have to weigh. There's time, this is a critical time. We know that bonding is super important. And I remember hearing plenty of stories of people who have been hurt or lost out on the opportunity to actually have a moment to bond with their baby. And that impact is long lasting. And it's not just for the baby, it's for the birther, and it's for the partner. We call it a golden hour for a reason. But in that golden hour, I work in hospital practice. In that golden hour, we're oftentimes not honoring the time of the parents and the baby. We're rushing to do things. And I get it. There's liability, there's documentation, there's assessments that need to be done. But again, this is quite a sacred and pivotal time in someone's life. And we need to honor that. We need to honor that. So those are just a few. There's plenty more opportunities for us to change our language and our behavior in this scenario.
Great. And I just want to thank you for bringing up the issue around, the formula feeding, because I think from a cultural perspective, there's always the myth and the assumptions that perhaps a Black woman is not choosing to breastfeed, and so we're just going to automatically bring formula. So I appreciate you bringing that out. So let's see, Dr. Billiard, can you respond to that first question as well? Give me your thoughts on how we can transition and change and respond differently.
Sure, thank you. I'd be glad to. If it's okay with you, before I give some specific thoughts on that, I thought I would share my own personal reaction because I thought there may be people on this conference that might resonate with my reaction as a white woman to the story. And I have to say, as a white healthcare professional, after my first reading of the story, my almost reflexive reaction or defensiveness or dismissiveness was to chalk it off as not really racism, but maybe arrogance, burnout, stress. We all get rushed. We all have to do things, maybe rudeness on the part of the physician and or the nurses, maybe cynicism of healthcare providers that we tend to develop after working in a hospital for a long time, or even hypersensitivity of a patient. And I don't know if these are things that some of the people on our conference can relate to, but in being completely transparent and honest, have to say that was some of the first reactions that I got after reading this case study. Luckily, I am in the hard work of unlearning some of these things that come natural to me as a white woman. And I took the time to really do some self-reflection and just spend some quiet time thinking about this case study from the perspective of the patient. And many things came to me, but it did take some time and quiet reflection, putting aside my kind of gut instinct. And things came to me both on the institutional level and the individual, but some of the things that I would say could have been different and most likely would have had a better outcome. One of the things was just the silence. There is a hierarchy in medicine, and sometimes there's an intimidation factor. And as healthcare workers, we are afraid to speak up when we see that something's wrong. But I think in this case, if some of the nurses or other people who were involved could have spoken up in a respectful way or advocated, or at least tried to mitigate some of the damage that was done by the physician, even showing some compassion, holding the mom's hand and asking how she's feeling, what her priorities are, what her concerns were, I think it would have really gone a long way to change the tone of the scenario. Advocating for pain meds. I think that is, as healthcare professionals, that falls well within our scope of taking care of our patients. And in the rush and urgency of a medical situation, it may take more than one set of eyes to see some of these things. And so I think that's something that we can all be held accountable for. Yeah, I don't want to take up too much time, but I think that's good for now.
Okay. Well, I would like to move over to Dr. Batra. So Dr. Bellier, something that you said I thought was very interesting is dismantling hierarchies in the obstetrical environment. So Dr. Batra, in the context of the question and the scenario, but also thinking about the hierarchy, can you somewhat speak to that and your thoughts on that?
Sure. Thank you for the opportunity. So I'm an OBGYN, and I will say that hierarchy is extremely important. But I think that there's a way to sort of shift that frame. And so I try to think about like structural, we've talked a lot about sort of like how individual level behavior and communication changes could have made a difference in this scenario. But I think also because I work like in a health plan at a system level, I try to think about, okay, well, how can we change these systems or structures to make better choices easier, the right choice easier? And so in terms of hierarchy, so I'll give an example. I know a lot of folks here have worked in healthcare settings or in hospital settings. So in terms of changes in how we manage medical errors and patient safety, right? We're really intentional about saying hierarchy doesn't matter. If you see something unsafe or something is wrong, you need to alert, right? Everyone has an equal voice in that space, right? I know some of like the OB nurses and folks are like nodding their head, right? Like this is something that we take really seriously for patient safety. And so I would argue that we should be applying the same framework of there's no hierarchy here when we see, racist thoughts, behaviors, policies being enacted or discrimination or bias, right? So maybe if we like sort of frame it in a way that's familiar to healthcare workers, we can sort of start to break that down.
Great, thank you for that. That's a very interesting concept. And Ms. Kadumu, can you also speak to the communication between the doctors, nurses, and Dana, and how we can move forward with change in terms of how we deliver care?
Thank you. Thanks for the opportunity to join you all. I think I would also piggyback on Dr. Batra. I think a lot of times we talk about individual behavior, but how can we really look at systems? So what are our systems doing to create a culture of respect and responsiveness? What are our systems doing to create opportunities to really make sure that our care is really around patient safety, experience, and outcomes, right? And so when that kind of guides us and drives us, then we can look at, that conversations that are happening outside and, outside where patients can hear inside, right? We're looking at some of the verbiage around the assumptions around the family, right? And also to comments about the patient's body, her ability to, hold pain. And so really looking at what are some of the systems levels that we can look at and what our hospitals and our institutions are doing to really just create opportunities for responsive and respectful care, and how we're really centering the patients and their families and treating them with respect.
Thank you.
This is Priya, can I just add to that? So like when I was just along the lines of what Mashariki was saying, as I'm listening to like the scenario, first of all, it's very painful to listen to because we've all seen and even maybe participated in little pieces of what happened to Dana and her partner. So it's hard to hear. But then I'm thinking, okay, like, first of all, why couldn't she access a midwife? Like, what can we do about that? What's the pipeline problem or the health plan or coverage problem there? Why didn't she have a birth plan? Why isn't that like standard? Why did she and Malcolm have to negotiate everything as they went along? Why wasn't that available to her? Why didn't she have a doula? That may have been really helpful to her around advocating. Why doesn't this facility have standard practices around everyone's offered breast milk first, right? Why was this a like individual choice for this nurse potentially, right? Why wasn't pain medication part of the checklist for any procedure? So I mean, like, just those are like concrete things we could do today that exist today, right? To like make the right choice easy, make the respectful way of providing care easier.
So Dr. Butcher, how do we, those of us who are clinicians who have some influence and voice in these settings, how do we move that needle to say, these are the things that should be standards of care no matter whom comes through the door? How do we support the movement of that needle with providers of all levels in provider care?
Yeah, that's a great question. I'd be interested to hear what other folks on the panel have to say. I'll say that as like a payer, right, as a part of a Medi-Cal plan, like we have levers from the top down, so we can, part of patient experience, like can we adopt some of these measures around like patient experience, respectful communication, discrimination, like to manage or to measure quality in our provider network, right? Can we look at disparities in cesarean birth rate, other complications, prenatal and postpartum, and look at how, can we flag that to our provider network and create some accountability there? So I think from our perspective, we have some levers we can use, but then I'm sure other folks have ideas as well.
So I'm going to turn that over to Ms. Mayana. Ms. Davidson, can you give some thoughts on how we can move and kind of move the needle around care, respectful care?
I have a lot of thoughts, and the core thought is the dismantling of the system that we are a part of, because this is a system that is corrupt. No matter how much we love what they pay us, no matter how much we love our coworkers, no matter how much we enjoyed our training, the bottom line is it's been toxic from the beginning. And so without the dismantling of it and breaking down of all these systematic barriers, I don't really see us going very far. And it starts with, I mean, there's several points. What I love to share the most is There's not one right way to do this. We need people in research, we need people in academia who look like me, who look like Black people, to really have a full understanding. When Dr. Belliard mentioned her initial, thoughts about this, my initial reaction to your reaction is like, but like I see these things on a regular basis happening to the people around me who look like me or Black and brown, and so not that you're discrediting what is actually happening, but so many people do discredit that. Dr. Batra, you mentioned too, like, how do we bring in more midwives? Like, that's part of it too. More midwifery access, more doula access, which, there's several foundations trying to work on that right now. But it starts in several different places. I can't change anybody's mind about how they feel about me as a Black person. That's the bottom line. But like how you treat me when I'm going into a system looking for care, there has to be a standard. There has to be a standard. And we were talking about, the hierarchy of medicine, again, a very toxic place. Like if you look at just how medicine works, aside from nursing, aside from patient care, it's demeaning. They don't offer time for rest. They don't talk to you about how to sustain yourself, and they talk down to people. I've watched it happen. I watched the breaking down of residents. I've watched the breaking down of attending physicians one to another. So what are we really doing? What are we expecting out of people who are acting and behaving in this manner for care to trickle down in that same way? So we talk about the hierarchy. Yes, as a midwife, I'm not going to perform certain procedures. There are patients that are not going to be in my care that I'm going to refer or co-manage with. And that's completely fine. My goal is not to take away any job. My goal is to provide equitable, quality care to people who are low risk, who need it and deserve it. But in that hierarchy, referral, et cetera, there's no safety. So we talk about speaking up about some of these things within the system, like, speaking, saying to the doctor, maybe that wasn't the best way you could have communicated to this patient, but there's not a level of safety. Sometimes when we say these things, there's a retaliation, whether it be on us or the patient who's in that room. I've seen the stories. You might have seen the stories on the news. So to bring it all back together, because I could talk for a very long time, I think that it starts with sustainability of programs and systems that are offering equitable care to everyone. The implicit bias training that is happening now that we're seeing across the nation, important. But when people already have their mind made up about something, it's very hard to change that. And that's not my work, but my work is to present the information and tell you this is what it is. This is what it is really happening. And my only hope is that people begin to believe us. We've been screaming for years. We've been called angry Black women. We've been called angry Black people. We've been called, all kinds of things. But when we're silent, we die. When we speak up, we die. So there's many different realms where we can tackle these things. And I'm going to just end there because, like I said, I could go on and on.
So you're kind of touching on what was going to be one of our questions, which is because there has been such a shift in how maternity care is seen, especially since COVID-19 and racial injustices, et cetera. Can you please share what ideal and equitable maternity care looks like to you? And Dr. Belliard, I'm going to turn that over to you because this is a very difficult space to be in, to be somebody who is Caucasian and having to step into this world and face these kinds of questions and concerns that come from African-American women in the BIPOC community. So what are your thoughts?
Thank you, Stephanie. It's a lot more difficult to be a Black woman and have to have some of these issues in real life to deal with. And I certainly am not the most qualified on this panel to speak about how we can make our hospitals a safe and friendly space for all of our Black mothers, but I have ideas for a dream hospital. I think that it would definitely include consulting with some kind of racial equity consulting firm and implementing anti-racism trainings for all healthcare staff, even doing poverty simulations in person, definitely providing or at least allowing for doulas and community health workers who can kind of advocate for the patient and be that trusted person who does have the time to listen and does represent and understand where the patient is coming from, whether or not the providers on call have ever seen the patient or have anything in common with them. I think it would be awesome to have an advisory board made up of Black patients that is regularly consulted and able to talk with healthcare providers. And I also think it would be, and this is very unrealistic probably, but if we really want to make a difference in our systems and make this a priority for the best outcome of our patients, I think it would be really helpful to have opportunities for debriefing and some guided self-reflection and talking about how things could have been done better, and having representation in those discussions, and really having an atmosphere where it's safe for not only our patients of color, but also our staff of color to speak up and be honest. And for those of us who aren't as close to the issue and aren't on the receiving end of these types of things as much, for us to really put aside our own initial thoughts and just listen to the people who are closest to it. So those are just a few. Oh, and one more, hiring and retaining Black health professionals, I think would make a huge difference.
Great, I agree. That makes a lot of sense. So Ms. Kadumi, I'm also throwing that question to you. What are your thoughts around the shift in maternity care and sharing ideals around equitable maternity care and what that looks like to you?
I think I would recommend some similar recommendations as Dr. Billiard. I think we have to have more accountability, and there has to be sort of hard stops, whether it's from pairs, other sources of accountability that really encourage people to do better. We have to look, it has to be multi-system. We have to diversify the workforce, the healthcare workforce. We have to create systems that allow more midwives and doulas to be in the hospital. So we can say we recommend doulas, but if they have barriers just getting into the hospitals, and not being able to assist their patients. I think some of the components of SB 65, which is the California Omnibus Bill, which is, looks at improving data collection, looks at increasing access to doula care and having that be a Medicaid benefit, looks at expanding Medicaid postpartum for 12 months, because we know women die once they lose their Medicaid, right? And that they don't have the opportunities to address some of the chronic conditions that impact the birth outcomes, looking to diversify the workforce. So I think looking at this multi-pronged approach really will change how we have respectful care, and really putting in some accountabilities. And those accountabilities go from pairs also to what Dr. Batra said, just setting up these systems within our settings, right? That we stop and that we really have standardized care that is respectful and advances equity for everyone.
And so, Ms. Davison, I'm going to throw that question back to you. I know you've touched on some of your thoughts, but what is your input around that question?
Can you repeat the question?
Oh, sure, absolutely. So basically, I just asked, because there has been such a shift in how maternity care is seen, especially during COVID-19 and dealing with our racial injustices that we've seen in the past year. Can you please share what ideal and equitable maternity care looks like to you?
Yeah, I think that many of us have already touched on that.
Yeah.
I'm a firm believer in midwifery access, accessibility. In the scenario, Dana's looking for a midwife and can't find one, and that's the reality. You go to more rural areas and 3 hours away is where you'll find a midwife, and that's not sustainable for a pregnancy and care. And if there's an emergency that happens during birth, we're putting lives on the line, So that alone, and then coming to a meeting of the minds. It feels almost as if sometimes, again, I think I mentioned this earlier, that midwives are trying to steal someone's job, and really that's not what we want to do. We want to bring that access to people who really need it. Right now, there's less than 6% Black identifying midwives in the nation, and that's inappropriate. Furthermore, in order to sustain something, we have to be trained in that work, right? In academia, where are our Black professors? Where are Black preceptors? Where are the people who are going to train us to do what we need to do? The studies do show we do learn a little bit better when we're being taught by someone who looks like us. That's not necessarily always true, just like getting care from someone who looks like you is not necessarily gonna save your life either. But you know, for the majority of cases, like that helps us. There's a level of understanding. There's a level of, I know your struggle. I know where I've been, where you've been, or I can at least understand it. And so really getting advanced practice providers along with physicians and the whole team together, like the teamwork, you know, we reinforce. I'm a Loma Linda grad. Like team is part of some of the core values, and so, but I don't always see that in the work that I do. And so, if we can all get together where we're talking about the issues at hand and hearing from people who really do experience these things on a daily basis, I like the idea of maybe having a patient panel that can be referred to. Also, in the scenario was mentioned the Earth app, which is an app that's out now where Black patients can report, or patients can report and rate hospitals based on what's happening. And that's real. That's like, it's like you're going into a lecture and you give a survey at the end. Like these hospitals will need to stand up and, you know, face the facts that are in front of them. Like you're not offering good care to people. And that's basic. That's very basic. Those are my thoughts. I mean, again, academia, we have our limitations there. And, you know, nationally, you see that in the news too, where people are denied tenure. And how do we progress and bring our people along, you know, if we're not allowed into these spaces? The other thing is creating our own spaces. So, you know, again, space, a home birth or out of hospital birth is not for everybody. I recognize that, but the access to that too, which might also take the edge off of some of this hospital lack of access. You know, our hospital rooms are full, and again, that's COVID related, but also like there's just been a boom and it's not gonna birth happens, like people are going to get pregnant. This is a job almost that you're secure in, like there's no denying that. But we don't have some of these spaces where people can go to, or if they have the spaces, they may not have the resources. So I'm speaking again from, and I always like to acknowledge this too, from a very privileged place where I say, oh, if you don't like your provider, find somebody else. Well, what if there is only 2 people in that group that this patient can go to because of their insurance coverage? And both of these people are not treating this person the way that they need to be, or hearing or understanding, taking time to listen. There's so many cracks within the foundation. Like I said, it all needs to be dismantled, and we need to rebuild up and start from a fresh space. So those are my thoughts on that part.
I also wanted
Oh,
to add, wanted to add, Ms. Stephanie, that I think another thing too is improved clinical and provider collaborations with community and community partners. You know, what I often see is that providers, clinical providers don't know where to send their families if they need assistance with housing or mental health, don't even know about the Black Infant Health Black Infant Health Program. So we really do need to really strengthen those collaborations. Our families are showing up, you know, in pregnancy, and they come with themselves, and for providers to be able to know how to, where to refer their patients, where can they get help, who can wrap their arms around their families during this time. And so there's some great stuff that's happening with PEI and other initiatives, but really the whole idea of bringing the clinical and the community organizations together to the benefit of our families is one aspect.
Yes, Ms. Kadumi, I agree with you. That's a very good point. I've heard oftentimes in the years I'm working with Black Infant Health, many providers saying that they've never heard of the Black Infant Health Program, which, by the way, has been around since the late 1990s. It is not a new program. We've seen a lot of new things happening, which is great, but it's not a new program. It's been across the state of California for many years. So I agree with you, the need to bridge that hospital community gap. Dr. Batra, I had another question of you. I know that IEHP has heavily invested, has invested in your doula services. And I really wanted to talk a little bit about what are the benefits of that so people really understand that, and how can we see that needle moved in other healthcare settings?
Sure. Yeah. So we actually partnered with Riverside Community Health Foundation since early 2020, beginning of 2020, to provide doula services at no cost to any of our members, IHP members who desire it. And that includes pregnancy, like prenatal visits, support during labor and birth, and postpartum as well. Been, I think, going, we've had good feedback so far from our clients who've participated. I saw this as important because one, there's evidence that it improves outcomes. Two, from the vignette that we just heard, there's a real need for advocacy in these spaces. And I really commend the doulas who are doing the work of essentially system change, right? We're putting them in these spaces where they're not always supported or known. And so that's like really important work. Still going. So if anyone needs a doula or knows someone who does, please contact us. And I think what's been really exciting is, we started this work sort of planning with our birth facilities and partners and sort of a lot of independent doulas in the Inland Empire in 2019. And since then, there's been a lot of momentum. So both county departments of public health through their PEI dollars are supporting doula work in some capacity, either pipeline support for doulas in training or actually doula services directly, which is great. We have other payers jumping in as well to provide doula services on pilot basis for their members. And then that sort of led to doula coverage being included in the governor's budget for 2022. So now comes the work of figuring out how this becomes a Medi-Cal benefit. And I think my sort of trepidation about that is, how do we keep the magic and the advocacy piece of doulas intact when it becomes part of a healthcare system, right? And I actually, just to go back to Ms. Davison, I really your idea of really reimagining this whole system resonated with me. I think right now, today, we're talking about how to reform and retrofit. This is a model that another nurse researcher in reproductive spaces talks about. So there's retrofitting, which is maybe this implicit bias training stuff. There's reforming, which is what we're talking about now. What can we do better in the system we have? But essentially, with doulas and all these other fixes, we're sort of protecting Black birthing people from the system. And then reimagining is the next step. So just to go back to that. But yes, so doula, I think as a result of all the momentum through groups like this and activism and policy work, now doulas are going to be a Medi-Cal benefit on January 1st.
Yes, thank you for that. And so, Dr. Billiard, do you see diversity in terms of doulas, midwives in your practice, and how is that accepted in your practice?
So I actually work in the NICU, so I'm probably not the best one to answer that question.
Okay, got it. That's right. Okay, so I will just move on to our next question, which is, how can we ensure more doctors, health providers are vested in seeing improved perinatal outcomes for African-American Black patients? And I will start with Ms. Kadumu. I think you're muted.
I think sort of going back to really the outcomes we want are improved patient safety, outcomes, and experience, right? And if we are improving the patient safety, outcome, experience for our most vulnerable families, we're going to improve them for all. And I think if we really just sort of really bring it down and make it more simplistic for people in terms of that, just really patient outcomes, experience, and safety. And then also to just some of the the efforts around implicit bias and cultural humility training that's been happening, but we know that can't happen in a silo, right? That you can't have your like 1 hour training and just really change our system, but really to how is that ongoing? So, a lot of people talk about implicit bias training sort of wash, rinse, repeat, wash, rinse, repeat. So what are systems happening? What is set up, protocols happening within your space that have this continuous care, continuous information around racism, being anti-racist, that have that we are uplifting physician champions that are involved in this work, that we are creating safe space for our BIPOC healthcare providers, that we are looking at the systems that really kind of drive the health outcomes and that really are holistic. And so it just really takes this multi-pronged approach that we really, to the very basic end. And if we can't, and I think sometimes it's just with accountability, it's really that's how we're going to drive change. Since people aren't going to just always drive change on their own. So what are the systems of accountability that we're putting in place to drive change?
Okay. So Ms. Davison, you want to answer that question? Do I need to repeat it or are you good?
No, I got it.
Okay.
As the question's being asked, I'm like, in my mind, circling around so many different points again. Foundation. I didn't learn about, background, I didn't learn about midwifery until I was in nursing school. But the funny thing is, my grandmother was a midwife in the island of Antigua. I knew nothing about this. I knew she was a registered nurse, but in her passing, I learned about her midwifery career. Early learning about the possibilities of what you can do and what it means is so critical. In undergrad, for me, I went to HBCU, historically Black college university, and the driving point, I was pre-med, the driving point was go be a doctor or go be a researcher. That was it, nothing in between. And while we need doctors, we need researchers. With that I don't see that promoted as much either, but we need those. We also need nurses, we need doulas, we need midwives, we need nurse practitioners, we need physical therapists, we need chiropractors, I can go down the list. We need mental health professionals, like it's all necessary. But then we get to the point of what Dr. Batra was saying about having these programs now incorporated and federally funded. How do we preserve the legacy and the integrity of what each system and each profession means without making it more toxic? Because we're throwing it into an already toxic environment. And so how do we preserve that? And for me, preserving the legacy of midwifery is critical. If you don't know, like Black midwives were already pushed out. They were told they couldn't do the work that they were doing, which was sustaining thousands of people in the South, because we weren't allowed access to hospitals. We weren't allowed access to white doctors. We literally carried our own people on our back. And then we're told we were doing it wrong. And so now we're at a place where we're doing it the right way, but we're still doing it wrong, right? And this way is not sustaining our people either. So our infant mortality rates are still higher than they were back in the 60s and 70s. That's ridiculous. So how do we preserve these new programs and professions and putting people in these places and allowing people to have more access without getting so muddled, and that's what the focus needs to be. I think that we have to, what I appreciate now, especially about what I see in the midwifery community, is the future of midwifery is radical. They don't take anything from anybody, okay? And they will speak up, but we need more of that, and also recognizing there's ramifications for it. Like I said before, sometimes there's a lack of safety in speaking up. And I've spoken with students who will message me and say, well, I said this, or I wore this shirt to promote, midwifery, and I was told I had to take it off. And they're relying on maybe a scholarship. They're relying on this institution to give them a piece of paper so that they can go out and do the work that's necessary. So it's gonna take a whole revamping of the mind. And like I said, a dismantling of the systems that are in place. Um, and there's opportunities for us to connect and to brainstorm and discuss like we do here. But then we need the little pockets to go out and fill in the gaps, and then also begin this work to just reformat the system. It really boils down to that. So early learning, talking about it early, you know, even as early as high school, earlier than that, letting people know what they can get into, and then placing specific people in academia who will help to sustain these learners, and then checkpoints within our system to say, check your bias. You know, does this person have access? How can I go out there to where they are and meet them where they are? You know, you'll see these studies of black birthers or black pregnant people who are not, they're not getting the prenatal care, and it's brushed off, oh, like they don't care. Do they have a ride? Do they have other children that they have to care for and go pick up? And these appointments, I mean, I go over in my appointments, and sometimes people can't sit and wait for an hour. They have to go and do certain things. So accessibility in a way, and meeting them at their need, their level, because at the end of the day, while this is a corporate business, it's really the business of being healthy and sustainable for your life. And we have to remember that it's about someone else's personal health journey too.
So thank you. I'm going to go ahead and jump really quickly because we have not a lot of time left to answer a couple of questions that are in the chat. So the first one I'm going to jump on is for Dr. Belliard. How can birthing families be stronger advocates for themselves in the NICU space? I have heard stories where Black moms felt slighted and forced with interventions like formula, pacifiers, inability to do skin to skin, lack of lactation, etc. Can you speak on that, please?
Sure. Hopefully, I mean, we do nowadays have lactation consultants, and baby-friendly hospitals are trying to really promote breastfeeding. Hopefully, all of our patients and all of our hospitals are getting the same support for that. And so I would recommend parents to reach out to their lactation consultants. But again, if we don't have, not just for lactation consultants, but for any of the healthcare providers that we interact with, whether it be the NICU or, OB or any other department in the hospital, if we are not representing our patient population, there's always going to be a disconnect. And there's going to be a lack of true understanding. There's going to be misunderstandings, which can lead to not we as healthcare professionals not doing our job, but maybe not doing our job in quite the same way that we do with other patients that we just connect to better. And so I think, again, it's critical to have the staff represent the community that they serve. And how do we make that happen? That's a longer conversation than we probably have time for here, but I really do think that is key to solving some of these issues. One thing that I think hospitals can do, and one thing that we have done at Loma Linda, and we're doing more of actually in the near future, is getting community health workers involved actually in the NICU. And they are a wonderful bridge between the community, the patient, and healthcare providers, because they are trusted members of the communities that they serve and that they come from, and they have that lived experience. They share that lived experience, and that is a person who has more time, is accessible, and whose sole job is to support the person. So I would, in an ideal setting, say that maybe that Black mother who has had those experiences could get matched up with a Black community health worker who could kind of bridge the gap between the healthcare professionals and herself.
Okay, thank you. I'm looking to see if there's any other questions.
If I may, there's a question in the box about what about the legacy is affected when a program is integrated into the already established systems. So in an age where both factual and non-factual information is easily and readily accessible, we can get caught up in what's right, what's wrong. But I want to give this example. Ask me if during my certified nurse midwife, not licensed midwife, not certified professional midwife, but ask me if in my certified nurse midwife training, if I was taught about the legacy of Black midwives. Did I have a class on that? Did they tell us the stories about what they did in the South to sustain? Did they talk about how Black mothers had to breastfeed both Black and white infants? Did they talk about how Black women have literally carried modern American anesthesiology and obstetrics on their backs in order to get us where we are today? People are only learning about these things now, so it gets muddled. They don't like to tell us the truth. They don't like to continue providing the historical context for the legacy, because you know what happens then? The truth comes out about our country. And I'm not afraid to say that, we have a really bad problem, and that problem is racism. And so so that's what happens, you know, when that's a possibility, let me say, when we introduce these specific programs and, you know, with the background of federal funding and things like that. I'm sure that the people who are starting these programs will try their best to hold on to and push down and share and storytell and remind folks of what it was like in the beginning. But at some point, when the money is involved and when the federal part of it is involved, it gets washed away. We can look at several different spaces for that. So that's what I'm saying, you know, what happens to the legacy of people like midwives, people like doulas. And then you get into a space where people don't even know what we do. Do you know how often I get asked, like, what's a midwife? And then, oh, you're a doula? And I'm like, no, I'm not. I love and support doulas, but my role is separate from what that means. And then that puts people in danger, because we also see people who are, as doulas, performing the work of a midwife, and they don't have the training for that. And that's not safe, you know? But to speak on the positive side of things, I think that there's a way that this can be done. It needs to be tactful. It needs to be full of checkpoints, and it needs to be led by people who have experienced and also support, know when to be quiet, know when to speak. People who can fund this and keep it going. There's so many different points for this to get done. It's just, are we willing to do the hard work? Are we?
Right.
You have to ask yourself that question.
Thank you. So we're going to, I know there's so much more discussion. I asked everybody to come back next week, but I am going to have to, and we do end at 1. I really want to thank our amazing and engaging speakers, Dr. Billiard, Ms. Davison, Dr. Batra, and Ms. Kudumu. Thank you so much for being here today. This has been just absolutely insightful information.